get started.
Okay. As Carrie said, my name's Tracy Poor, and I work with MMIC. We're a medical professional liability insurance carrier. I think some of you are actually customers of ours, based out of Minneapolis, Minnesota, but we cover close to 30 states at this point in time. I live in Kansas. I cover Kansas, Colorado, Oklahoma, Missouri, and the southern half of Nebraska. So I've been with MMIC for about 7 years. I work from my home in north central Kansas. But pre-COVID, I did a lot of traveling, out to facilities to do risk assessments, or I gave a lot of education. I speak at a lot of association events. And then the days when I'm in the office, I do a lot of just answering questions. Is this records release valid? We have a patient who their family member is upset and they're asking questions. What can we answer? We had an adverse event happen. How do we communicate that? How do we document that? So just a lot of the day-to-day risk management questions that come up. I'm a resource for all of our customers to call, email, and hopefully find answers to those questions. So today's program, Carrie's correct. I gave it about a year ago at the Northwest Missouri MGMA. And what this program really does is it just helps link the risk management process to the entire organization and how your risk management process relates to provider success, how it can lead to claims against providers or claims against your facility, even with appropriate clinical care. How it can affect financials within your organization, and just how building and maintaining a robust risk management process can really benefit your organization as a whole. So first, I always like to kind of give a roadmap of what we're going to look at. And we're going to look at how the risk management process is used to prevent patient injury and improve business performance. How do we develop interventions to reduce identified risks and enhance patient safety? And how do we evaluate our existing risk management plan? What does our plan look like? What do we actually do? And what's an effective way to streamline our risk management plan so that it works for us, but that it's still something that's reasonable and something that our employees can follow. We don't want to have it be so cumbersome that it's not realistic for our employees to be able to follow our plans. I do always like to start off with a case study. I give several case studies throughout my programs just because I really feel like it helps make the things I say real. I can stand up in front of a group all day and say, this is what you should do. But if you see instances where it either happens well or it doesn't happen, and either a lawsuit entails or a lawsuit does not happen, it really helps drive home the points about what we recommend for our providers to do. So this case involved a 43-year-old woman who saw her family practice provider for her annual well woman exam, had a screening mammogram ordered. The radiologist noted that there was a nodular density in the right breast and recommended an ultrasound for further evaluation. So the family practice provider reviewed the report and ordered the ultrasound, communicated it to the patient. The ultrasound showed that there was a suspicious lesion, and the radiologist recommended an ultrasound-guided biopsy of the area. So the family practice provider referred the patient to the surgeon for the biopsy. The report came back and it indicated that there was benign breast tissue and no evidence of malignancy. But where the issue was an addendum that came in later to the biopsy report stating that the results were not consistent with the ultrasound and that there could have been a sampling error, and it recommended redoing the procedure to make sure that the results were consistent or having a surgical excision of the suspicious area. And what happened was there was no evidence in the record that the family practice provider ever reviewed the addendum report. The initial report, we have documentation where, we have timestamps where the provider received it, where the provider reviewed it, where the provider communicated it to the patient. We don't have that with the addendum that came in after the initial report. So we don't know if the patient ever received this information. And as it always happens, the patient is going to say, I did not receive this information. They're never, when we have a lawsuit, the patient never says, well, yeah, they told me, but I just didn't do it. And without documentation that it happened, we don't know if it happened or not. 2.5 years later, same patient came in, saw her family practice provider for thickening in the right breast, ordered a diagnostic mammogram, and it indicated a 2x2 mass that was highly suspicious for malignancy. They did a biopsy, and it revealed invasive ductal carcinoma. So we had 2.5 years that passed between the initial suspicious finding and the actual diagnosis of cancer. This patient underwent surgery and chemotherapy. She did survive, but she filed a malpractice claim alleging an almost 3-year delay in diagnosing breast cancer and a lost chance of survival. And what this case hinged on was the likelihood of reoccurrence because of the delay in diagnosis and the delay in treatment. Experts were critical. We always have expert physicians analyze all of our case files before we do anything with them, before we decide, do we go forward, do we not? They were very critical of the follow-up systems of this facility and this family practice provider, and the fact that we could not tell if this patient ever received the results that were communicated in the addendum. So this was a claim that we did have to settle against the family practice provider and the clinic. So there were 2 claims against 2 different plaintiffs. Because again, we had no evidence of what information was given to the patient. So with the information that they had, the family practice provider acted appropriately, because we don't know if the family practice provider saw that addendum. And without knowing that, we don't know if their actions were appropriate or if they were inappropriate. So this is where our systems come into play, because we didn't have a good tracking system of when reports are received, when addendums are received. Do we make sure that that gets in front of the provider? I just had another case almost exactly like this, where, and it was a frustration with the radiology provider that they would send 3 or 4 copies of results or reports for the exact same screening test that was done. Sometimes they were different, sometimes they weren't. And of course, we had one that was different and it was missed because it's fatigue, it's results fatigue. You get 4 or 5 faxes in a row from the same person and they all look the same. You're probably not going to read them for the minuscule differences that are in there. So we want to make sure that we have good processes and good procedures for catching these types of instances that come across. So risk management and patient safety. Our approach is that it's a proactive process in preventing patient injuries, which then prevents claims, which is where we come into play and where we step in. ASHRM, which is the American Society for Healthcare Risk Management, they define risk management as the identification, analysis, and evaluation of risk and the selection of the most advantageous method of treating it. They view risk management processes as a cycle. We identify the risk, we analyze it, we intervene, we make changes, and then we evaluate. Did our change work? Will we hopefully stop this from happening again? And then we start it all over again. It's a never-ending process of identification, analysis, intervention, and evaluation within our facilities. So we look at the first step in that process, risk identification. How do we identify potential adverse events? How do we employ early interventions, build knowledge, identify trends, and create strategies to help mitigate those trends that we find? Sometimes we look at trends in our facilities and we find a completely different answer than what we thought we were looking for. We had a facility where they were seeing a large number of hospital-acquired infections within their facility. So they started looking at the patients that had these hospital-acquired infections, and they noticed that they were all treated on the same floor. And then they started looking even closer, and they were all on the same wing, and they had one nurse in common. And so they started digging a little bit deeper, and they found that this specific nurse was skimming IV pain medications off the IV bags before administering them and refilling them with saline, and was contaminating the bags when she was doing so. So here they thought they had one specific type of problem, and once they saw the trend and they dug deeper and they really looked at it, they found out that it could all be traced back to this one individual. Maybe their other processes weren't bad. Maybe their housekeeping and their cleanliness and their procedures weren't bad, but it was this one individual. And so then they were able to institute changes where, no one individually is administering pain medications or other high-risk medications to patients. So that's an example where you can look and identify your risks by looking holistically at a lot of the things that go on in your facilities. Some tools that you can use within your facilities. This comes from AHRQ. It's the Agency for Healthcare Research and Quality. And they have surveys on patient safety that you can take. And these assessments should involve all levels of your staff within an organization, your medical staff, your governing board, your employees, because a lot of times different levels of employees within your organization will think your process is something completely different. If you ask your administrator, what's our process for this? They might answer something. And then if you ask the employees actually carrying out the processes, it might be something completely different. So we want to make sure that we get a broad sample when we fill out surveys like this or self-assessments, ways that we identify risk. We want to make sure that we're doing it across all facets of our organizations. Some other ways you can assess your safety culture is to raise awareness within your organization. You may or may not have heard it. We hear it ad nauseum in risk management, but everyone is a risk manager. But it's true. We have had housekeeping staff identify potential risks. They might, notice that there's a loose handrail in a long-term care facility. They might notice improper storage of chemicals. They might notice a wet spot on the floor that makes someone a fall risk. So we want to make sure that we're raising awareness across our entire organization regarding risk management and the importance of risk management. Assess your current culture. Look at how do your employees view risk management currently. A lot of facilities I go into, once I start speaking to employees, they'll talk about how they don't trust risk management. It's a witch hunt. They're just trying to find someone to blame when something goes wrong. There's not a great relationship a lot of times between employees, providers, administration, risk management. So we want to make sure that we're fostering a culture of cooperation and we learn from each other. We're not looking for incident reports so we can punish people. We're looking for incident reports so we can prevent these things from happening again, so we can learn from them. Risk management should not be a punitive department. They should be a learning department. We need to identify our strengths and weaknesses within departments and as employees. Maybe someone is really good at identifying potential risks. Some people just have that brain. They can look at something and say, no, these are all the ways that this could go wrong. Or what if this happened? And so we can really look at our processes and see where they're strong and where we might have breakdowns within our processes. And look at trends in your culture over time. Have you had a certain number of years where you've had high turnover in certain departments? Was it related to management within that department? Was it a higher level administrative issue? Look at the culture within your organization over a period of time and try to identify what the driving factors behind those changes in culture were, especially the ones that work well, and say, okay, this department works really well together. They're very positive. They're very proactive. What are they doing differently than the other departments that maybe aren't as progressive or working as well as a team? Some things within your culture of safety values. Again, commitment to safety at all levels. Every person within your organization needs to feel invested in the risk management process and in the outcomes. We need to make sure that we're allocating necessary resources to risk management, that safety is our value as a priority over production. It's great if you can see 30 patients in a day for the bottom line, but if we're not being thorough, if we're not being sufficient, if we don't have time to appropriately document what we need to, that's not efficient as an organization. You're putting yourself at increased risk. And I'm pretty sure most providers don't want to take 10 months off to deal with a lawsuit. Then their production really does go down. Communication needs to be a defined process. Who do you go to when? If you have a question about medication administration, or if you have a concern about a coworker or a patient, who do you go to? There needs to be a clearly defined process for communicating with risk management. Openness about errors needs to be normal. We need to talk about things. If we have a near miss, if we have a deviation from the standard of care, if we do have errors that occur, we need to talk about them, because that's how we learn. And 99% of the time, those things don't happen intentionally. So again, we need to take the punitive aspect out of it, and make sure that we're approaching it from a method of learning about how to improve our processes. And again, learning from our errors is the goal. It kind of feels like parenting sometimes. It feels like, I want you to come to me. I want you to tell me what happened so that we can talk about it and we can move forward and we can learn from it. So that's really our end goal here, because that improves patient care, that improves the culture within your organization, and it's going to help your bottom line in the long run as a facility. So another way you can identify risks within your organization is looking at patient experience surveys. We all have, Press Ganey or whatever you use within your organization to have your patient satisfaction surveys. Look at those, read those, and don't just read the negative ones, read the positive ones as well. Maybe a certain nurse stands out often in your patient satisfaction surveys. Ask that nurse, how do you do things? Why do you do things this way? It's a great way to identify problems, but it's also a way to identify things that work well within your organizations. It can uncover your weaknesses, and it can help identify potential risks before they become complaints or claims within your organization. Again, patient complaints, that's a great way to find areas where patients are unhappy. If it's a valid complaint, and you guys are all good at sorting through the ones where this is just a crotchety patient versus this really was a problem. I had a facility once, and it was listed in a lot of their complaints. A lot of patients had just accepted it because it was the way their facility was built. But the registration desk was on the first floor. The third floor was the actual clinic, and the fourth floor was where lab, radiology, all of those services were. So, you went in, with your sick child or your sick elderly parent to the third floor, checked in, saw the family practice provider. They ordered an x-ray, they ordered lab, whatever service they needed. So then there was no one to check you in on the fourth floor. So then you get back on the elevator, go back down to the first floor to registration, fill out all of that paperwork, get registered for lab, radiology, whatever they needed, back on the elevator to the fourth floor to get lab, to get radiology, and then back down to the third floor, back to the family practice provider's room to wait for your results. So that's irritating on a normal day, but if you have a kid with a fever throwing up, if you have a fever, you don't feel well, you have someone else you're caring for, that's a really irritating process. So you can imagine if something doesn't go well, that patient's already dissatisfied just with the process. There were challenges with their building, but they figured out a way. They put registrars on the third floor and the fourth floor. So as you were leaving the third floor to go to radiology, you could register there, or you could go up to the fourth floor and register before you go into the radiology or to the lab. So they looked at their complaints about how time consuming and how inconvenient of a process that was, and they found a solution that worked for patients and for providers. And they created 2 new jobs within their community, which is great. 70 to 80% of patients who seek legal advice after an adverse outcome are angry. And this doesn't just mean angry in general, because it's natural to expect someone to be angry after an adverse outcome, but they're angry because they can't get answers. They can't get their medical records. They can't get someone to answer their questions about what to do next. They get a bill for something that, when there was an adverse event, we always say hold the bill until we've done an investigation and we know what has happened, because nothing's more infuriating than receiving bad care and then getting a bill to pay for it. So what we recommend is just have someone who is able to communicate with these patients. We encourage open, honest, transparent conversations when there is an adverse outcome. Because patients deserve to know it's their health care. I wouldn't take my car in to get the oil changed and have something get broken and not expect an explanation. So I don't know why we expect patients to not want to know what happened with their own healthcare. But just having that initial conversation with patients and making sure they have a contact person can really help dissipate that anger and build the relationship. And we found up to a 60% reduction in claims just with open and honest communication, or just being there to answer questions after an adverse outcome. Like I said, most of the time the patients just want answers, they just want an explanation, and they want to know that you sympathize with what they're going through. Some more tools for identifying risk: incident reporting systems. It's an adverse outcome report, event reports, incident reports within your facility. Look at those reports, even if it's a near miss, even if it's a variance that doesn't have an adverse outcome, there's no injury reported. Look at those and see how our systems failed. How did they call it the Swiss cheese model of risk management. They say, you know, healthcare is like Swiss cheese. There's holes everywhere, but every once in a while, all of those holes line up and something falls through. So how do we prevent that from happening within our systems? Some of the adverse outcomes and incidents that occur because of failures within these systems: missed fractures on x-rays, you know, if we don't have overreads done, or if we don't read the report on the overread; missed or delayed diagnosis, like the first case we talked about; medication errors; falls in the office; wrong procedures; just something as simple as scanning in a drawing before a procedure and labeling that drawing. We had 2 cases where everything was electronic except for the drawing that the provider did prior to the procedure. One was a thyroid and one was an ovary removal on a young female, like in her 20s. Had one diseased ovary, one healthy ovary. Provider drew a diagram. It was scanned in prior to surgery. It was not labeled left or right, and the image got flipped, and they removed the only healthy ovary that this young woman of, you know, young reproductive age had. So that was one that became a settlement. And then the one with the thyroid, the exact same thing happened. They removed, you know, they got in there and they removed the wrong side of the thyroid because there was a drawing. It wasn't labeled left or right. The image got flipped when it got scanned in. So something that you don't even think about, you know, but we want to make sure that our procedures support preventing those types of incidents from happening. Risk assessments, they're another proactive way to look at potential risks and identify potential gaps in your organization. We have several of these on our website. A lot of them look like the AHRQ ones that I showed you in an earlier slide. And again, make sure that you have several different people take the same assessment, because you will get different answers. And that's step number 1 in identifying where your risk is. Where do we not match up on what we do, what we think we do, and what we say we should do? Those are all 3 very different things. And looking at your malpractice claim data. You know, most practices don't have a lot, thankfully, but what we do is we code all of our claims. So this is information from the claims we received as a company across all of our states from 2010 to 2015. We take about 5 years worth of data at a time and digest it and look at where do we see risks occurring across all of the claims that we see. And so what we do is we code them by the main allegation, we code them by cost, and then we look at contributing factors. You know, maybe the main allegation was a misdiagnosis of cancer, but the contributing factors were poor documentation, or we had we didn't notify the patient, you know, we had a communication issue. It wasn't that we didn't read the x-ray or the mammogram report correctly. We didn't communicate it. We didn't document it. We didn't make sure that the patient kept their follow-up appointment, and that's how it fell through the crack. So when we look at all of our outpatient claims as an organization, if you look at the dark blue bars is the occurrence of cases. So surgical, and it makes sense that surgical is the highest occurrence of cases that we see. Medical is just improper medical care. That's, you know, we gave the wrong medication, or we administered the wrong dose of medication. We started the wrong course of treatment. And then diagnostic is delayed or missed diagnosis. And so then if you look at the light blue bars, that's total incurred cost. So while diagnostic error is the third most popular cause of action, it's the most expensive cause of action. So it costs us more money than surgical and medical does. So we thought that was interesting that it was the third most frequent allegation, but it was one of the most expensive allegations because it involves subsequent care, lost chance of survival, all of those things. And these risk reports are something that I can send out. We have them in PDF form, and we update them, like I said, when we get more cases. So if any of you have interest in that, I have my contact information at the end of this program, and we have them across several different areas of practice. This one looks across all settings. The prior one was just in the outpatient setting. This is across all settings: inpatient, outpatient, hospital, clinic, all settings that we have. And it was still the same three: surgical care, medical care, and diagnostic error. And it was still the number 3 occurrence across all settings, but it was the second most expensive across all settings. So if you look at it just in an outpatient, it kind of makes sense because, you know, your more complex surgical procedures are not going to be done in the outpatient setting. They're going to be done in the inpatient. But when you add those in to all types of facilities, then your surgical costs go up because those are going to be your more complex surgeries with, you know, more complex care that's involved. But again, diagnostic error kept popping up when we were looking at our cases. So when we look at just diagnostic error cases across our facilities, almost 60% of those originate in the outpatient setting. 18% happen in the inpatient setting, and then 24% happened in the emergency setting. So then we started looking at what is the diagnostic process. And there's this 12-step process that has been established by CRICO, which is where we send our data to be analyzed. They're actually the malpractice insurer for the Harvard Medical Group, but we actually have access to their information and to their data. And so that's where our partnership with CRICO comes in. And they developed this 12-step process to looking at the diagnostic process and where do most of the failures happen. And when we looked at that, 45% of the time, the error occurs in the follow-up and coordination phase of the diagnostic process. So it's not ordering the wrong tests. It's not interpreting them incorrectly. It's not giving an incorrect differential diagnosis. It's following up with the patient. It's management of referrals and consults. It's making sure that patient information is communicated among the care team. Like that first example, we know the nurse saw that addendum, but we don't know if the nurse communicated it to the provider, if the nurse put it on the provider's desk like they always do, and the provider just signed off on it and went on down the road. So making sure that we're communicating among our care teams, and then making sure the patient and providers establish a follow-up plan and follow it. So that's where almost half of our diagnostic error cases occur. So the clinical care is not the issue. So then we looked again, and when there was follow-up system failures in our outpatient cases, we said that even when the appropriate clinical steps are done, we still have a case for diagnostic error because the issue is not the clinical care, it's the system that failed. Either way, the patient was injured, and they're not going to care if it was the process that messed up or if we made a wrong clinical judgment call. All that matters legally is that the patient was injured because of some action or inaction on the part of the provider or another member of the care team. So how do we analyze these steps? This is just another way to look at it. It's a risk matrix, and you can list what types of risks you have, and then you can fill in this grid. I don't know if you can see it. The top labels is, you know, very low severity, you know, how severe is the injury if this happens. And then on the left, the vertical bars, is it, you know, is the risk very high frequency, medium frequency, low frequency, and then that helps you identify within your grid where your high risk, high severity, high frequency cases are to know where you should start. If something's in the green zone, maybe that's not where we focus our energy. But if we have a risk that falls in the red zone, the orange zone. We want to make sure that we tackle those processes and those procedures first to make sure that we help mitigate those risks first. And so that kind of helps us look organization-wide and figure out where to start, because it can be overwhelming. You look at all of the areas where risk or patient injury can occur, and you think, where do I even start? So this is a good way to help analyze and figure out where to start. Some other ways to analyze the risks that you see: root cause analysis, or a failure mode and effect analysis. Your root cause analysis, it's retrospective. It's after the fact. Something has happened. Now we need to find what the root cause of this injury was. It's multidisciplinary. It's not just the physician. It's not just the nurse who was there when the error occurred. It's everyone that's involved in this patient's care. So we want to make sure that we have more than just one or two parties involved. It's a step-by-step investigation. We look at the root causes of the error and what happened, and then we come up with prevention strategies. How do we prevent this from happening again? How do we make sure that we don't have another patient get injured in the exact same manner that happened here? Some things to look at when performing a root cause analysis. First off, what happened in this situation? And then these next two are two different things. What usually happens, what is our norm, and what should happen. Again, I mentioned earlier, if you look at your policy, or if you ask several different people at several different levels of staff within your organization, what is our policy, you might get different answers. And if you ask them, what do we actually do, you'll get a different answer. Staff are great at finding workarounds. We had a facility that decided they were going to require, appropriately for HIPAA reasons, all nurses to lock and sign out of their computer every time they got up, and then they would have to sign back in every time they got on, which is appropriate for privacy reasons and security reasons, but it's not very efficient. Nurses probably get up 75 times a day at least, every time they see a patient, then they go back to their workstation, back and forth. So what the nurses figured out was, well, if I just shut my screen off, it looks like I logged out, but it's a lot easier to just come back to my machine and turn my screen on. So it's a workaround. So we want to make sure that we're not developing processes that are so cumbersome. The solution for that was they got everyone the badge sign in, so you could just scan your badge at your computer and it would fire right back up. So it was locked when you were away, but then you didn't have to go through the process of logging in. I know our login process is like 3 steps. So thankfully I only have to do it a couple times a day when I'm away from my desk. I'm not up 75 times a day. So we want to make sure that we're catching those types of workarounds, shortcuts, ways that we're working around our policies. And sometimes it's not an issue of enforcing the policy. It's maybe we need to change our policy. Maybe we need to make some changes to make this more efficient and more workable for our staff members while still accomplishing the same goal. Some other aspects of root cause analysis: why did it happen? How do we prevent it from happening again? And how will we know we got better? One of the biggest problems with risk management is you don't always know that you're doing a good job because the things don't happen. We're trying to, filter water with our hands. It's, we know if something bad does happen, but we don't know how many bad things we prevented from happening. So how do we measure success as an organization? How do we look at that? So sometimes that's a difficult metric to find within your organization. A failure mode and effect analysis is another way. This is before an event or error occurs. So your root cause analysis is looking at an event after it happens. This is looking at how our processes could fail and how do we prevent them. So it's a matrix that you fill out again, and you look at every step in your process. Say you want to look at ordering test results and following up on test results. What is our process? So we list down what every step is. And then on a scale of 1 to 10, how likely is what we are looking at in this specific step to fail? What's our failure mode? If, someone doesn't read the report, what's the cause of that? Maybe we receive way too many reports in a single day. We don't have a separate place. We can't flag reports in the medical record that come in that are different, or addendums. What's the effect of that? We miss a breast cancer diagnosis by 2.5 years, potentially. What's the likelihood of occurrence, the likelihood of detection? How are we going to know if there's something floating around in the electronic record that no one has looked at? What is the severity of injury if it does happen? And then you take those numbers and you add them up, and that's your risk profile number. And again, that shows you where to focus your efforts first, and where within our processes are we most likely to fail or to have an error occur. So again, this is a prospective analysis, where the root cause analysis is one that you're looking at after the fact. So the next step is intervening. How do we try to mitigate the risks? Really, the only way you can ever eliminate a risk is to cut a service. You know, I'm thinking of small rural hospitals who have cut OB services because the risk to them, it's a cost issue also. You know, if they don't have anesthesia available 24/7, that's not something they can do. But a lot of them have eliminated it from a risk perspective because it's not something that they are adequately equipped to handle. So that's really the only way you can eliminate any type of risk. Preventing the risk, you know, you can attempt to reduce the recurrence with the use of your policies or reliable processes. An example of that is requiring radiology overreads of all x-rays read by non-radiologists. We found, I believe it was a 66% reduction in missed fractures when there is an overread by a radiologist. So that's a way that you can help prevent and mitigate those types of risks and those types of claims. Controlling the risk, you know, giving immediate feedback and corrective action in response to a patient complaint, developing a good communication plan, designating a spokesperson. Again, we talked about that earlier, how patients are just, sometimes they're just angry and they just need to vent and get it off their chest and know that you heard them, know that you sympathize with them, and then they're okay. Then they want to move on. Another step is risk evaluation, data collection. Look at your event and incident trends. Again, you might find, you know, that one wing on that one floor where you're receiving a lot of hospital-acquired infections. If you look at it from a broad scope, you think, oh my gosh, we have a huge problem. But once you really start to drill down and look at the trends, a lot of times you can identify where your risk is occurring. Periodic policy and procedure review. Regulations change all the time. Staff changes, staff capability changes. We want to make sure that we're reviewing our policies and procedures to reflect that. And medical record audits. And it's not just administration auditing. Have all your providers sit in a room and look over 3 of each other's charts and say, I can tell what you did here, or I can't tell what you did here, or, you know, a lot of times that's how providers identify gaps in their own processes or procedures, is if they have one of their peers say, oh, well, this is how I do it, or, oh, I almost had this happen to me once. You might want to change the way that you did this. So record audits are a really good way to make sure that we're doing what we need to do and that we're providing the highest level of care that we can. Your risk quality and patient safety program, it starts at the top. You have to have commitment from leadership. Your board needs to understand the importance of your risk management processes and procedures. You need to have administration and physician buy-in, and they need to promote it and support it. I've been in so many facilities where the leadership among the medical staff hates risk management, and that is, you know, that goes throughout the entire facility. If the doctors don't trust them, if the doctors don't like them, the nurses aren't going to, no one is going to. So we want to make sure that we have commitment and buy-in and support from leadership. And if that means making changes, that's okay. Because we want to make sure that we're not just providing lip service, but that we really are invested in these types of programs because we know the importance within our facilities. Have designated accountable individuals. This is for staff to come to, this is for patients to come to, and they can be different individuals. We want to make sure that people know where to go and that we have people holding everyone accountable. Again, a defined communication process that's internally and externally, and have a written comprehensive plan for risk, quality, and patient safety. So if we need to reference what we should have done or what we should be doing, we have that available. And we do want to make sure that exists, because a lot of times plaintiffs' attorneys now now that they're not having as much success with medical malpractice claims, they will ask for your policies and procedures. They will say, do you have a written risk management plan? Do you have a written policy and procedure? And if you don't have one, sometimes they can attack you as an organization. And also, if you have one that's too cumbersome, again, this is where having policies and procedures that your staff can actually comply with comes into play. Because if it's, people hear these programs and they say, oh, we're going to go throw every protection we possibly can into our policies and procedures. Well, then if it gets in the hands of a plaintiff's attorney and your staff wasn't following it, they're going to say, oh, not only did you commit malpractice, you have a claim now for failure to follow your policies and procedures as an organization. So we want to make sure that we're not backing ourselves into a corner with our plans. The role of the risk manager within your organization, it sounds cliche, but they wear many hats. Some facilities have the office manager, the administrator, some have the nurse. I've been in some really rural facilities where the risk manager is also the quality person, who's also the director of nursing. And they got that job by being the nurse that was there the longest. They have no formal training. So we want to make sure that we're supporting our risk managers in all of the hats that they have to wear, and making sure that they're having the education and the training that they need, and that they have the support that they need from our administration. This slide always bothers me. It's supposed to communicate about silos within an organization and how one department doesn't necessarily talk to the other department. We might be duplicating steps. We might be skipping steps. I grew up on a ranch in north central Kansas. These are grain bins to me. They're not silos, but I think maybe that's a Midwest thing, because I Googled silos looking for an image and this comes up. But I always have to stop on this slide and express that to me, these are grain bins, but the sentiment is the same. They're separate. They all contain their own contents, and you're not going between them. And oftentimes, if we just stopped and asked radiology, hey, did this person come in? Hey, did we get a report back on that? If we communicate across departments, we can catch a lot of these issues before they become injuries or before they become claims. So we want to make sure that we break down our silos and we communicate across our silos or our grain bins within our organizations. Some integration of risk, quality, and patient safety. Across our organizations, we have data collection from all aspects. Data sharing. We want to make sure that we're sharing. Like I said, if radiology had an incident occur, we want to make sure that we're sharing what happened and what we learned from what happened. Investigation of events, performance improvement projects, team education and training. It does us no good to have all these great policies if we're not training our teams on how to follow the policies and what their obligations are under these policies. And leadership reports. We need reports that go back up the chain of command to leadership. These need to be, discussed at med staff, discussed with the board, so that we can have leadership involvement, because that helps increase leadership buy-in within our organizations. Some elements of your risk management plan needs to have your purpose and your goals, who has authority and accountability within your organization, what are the functions of your risk management team, what are the policies, and then we need to evaluate the plan and say, okay, is this all inclusive? Does this cover what we need it to cover? And is it reasonable for our staff? And does it promote a culture of reporting and communication and learning, as opposed to promoting a punitive culture of risk management within our organizations? We want to make sure that we have crisis and disaster preparedness plans within our risk management plan. You think of Greensburg, Kansas, when the tornado came through and just wiped everything out. Did they have a plan for that? Floods, hurricanes, in the Midwest, we get all sorts of weather issues. Or what if the power goes out and, we don't have good generators? How do we access our electronic health records? Media crisis relations. How do we communicate with the media? Or if someone's on Facebook spouting off about their bad experience, how do we communicate with those patients? We actually offer a service. It's a crisis communication consulting firm that our clients have access to as part of their policy. If they have a claim or an incident that occurs within their organization that they feel like the local media might get a hold of, or the newspaper, you know, someone might be on Facebook. We can hook them up with Padilla, and they help them train their staff on what to say, what not to say. They help craft a statement to release to the media. So we want to make sure that we have processes in place and that we train our staff on that as well when we do have those types of situations. What is our incident reporting and investigation process? Do we deal with cybersecurity? What if we have a cyber breach? How is that handled within our organization? And how do we handle patient complaints? Who gets those? Who communicates quickly with the patients? Who makes decisions in regard to that? How do we handle those types of issues? We want to make sure we have a claim handling process. We look at regulatory compliance, you know, your medical device reporting requirements. If it's a device that malfunctions, HIPAA, EMTALA, the National Practitioners Data Bank, state reporting requirements. We want to make sure that our plan complies with all of those aspects as well. What is our peer review process? What's our method for privileging and credentialing new providers or re-credentialing providers that are still here? And what is our disclosure process when we do have a harm event? If we do have clear liability or, you know, clear injury to a patient, what's our disclosure process? And we actually have a program, it's called HEAL, where we encourage early intervention, early conversations. So I always recommend, even if you're not with us, contact your malpractice carrier, and they can help you with those conversations and that disclosure and how to quickly address those issues so that the patients aren't getting more and more angry as they're waiting for answers from their providers. When we review our policies and procedures, we need to be doing this annually. Update these when services or care processes change. You wouldn't believe the number of facilities I've gone into where they eliminated 2 or 3 types of services, but they're still addressed in their policies and procedures just because nobody thought to delete that or to get rid of that policy. We want to make sure that we document, review, and revisions. We need archives of outdated and terminated policies because you're going to need the policy that was in place at the time of the incident. So in Kansas, for example, you have 2 years to file a lawsuit from the time of the injury or the time the injury was discovered. So if you're injured in 2018 and then we change our policy in 2019 and the suit is brought in 2020, giving them our current process or procedure isn't going to be effective. So we need to make sure that we have our old policies archived so that we can say, well, this is what our process was when this incident occurred. And then we need to have retention and destruction guidelines for archived policies. If a policy is 15 years old, then it's probably safe to get rid of because your statute of limitations is run. But that's something that your facility attorney can advise you on the record retention laws within your states. Risk management plan, the whole purpose of it to help your business. You know, we always try to make a business case to how it affects the bottom line. We can reduce inefficiencies. We can improve productivity. We have a higher reliability organizations within our care processes. A reduction in patient injuries, obviously that leads to fewer malpractice claims. Prevention of unnecessary hospitalizations, readmissions, you know, there's reimbursement implications for those now. Improved patient experience, patients talk. Better care coordination, fewer diagnostic, surgical, OB errors, fewer errors in general. And again, fewer malpractice claims. So from a business perspective, you really can improve your business performance with a robust risk management plan. So kind of our tagline is always that, you know, risk management, it's good for patients, obviously, it's good for care teams, and it's good for your business. So those all 3 tie together. I mentioned those risk reports. My email address is right there at the bottom, so I'll leave this slide up for a minute. And if anybody has any questions, I'd be happy to try to answer them on the spot.
So I'm going to go ahead and unmute the phone lines so that if anybody has questions, you can ask them of Tracy. And I've unmuted lines, but if you're on a cell phone and you've muted your line personally, you will still have to unmute that line, by the way. Okay. Tracy, when I heard you, just somebody have a question?
Oh, this is Brad Carney from Northland Family Care. And Tracy,
Go ahead, Brad.
all of this it seems almost overwhelming from where I sit. Private practice, about 5-6 providers. What steps would you recommend to take first to be sure everything is in order? We obviously do have a risk management plan in place, but I don't know that it's been reviewed lately.
Yeah, and I would
start
with just, and are you Kansas or Missouri?
Missouri.
Missouri, okay, and I know Kansas outlies pretty well in their statute and regs. I would assume Missouri does the same. I would have to double check. But their statutory requirements are pretty well laid out. So I would encourage you to look for those. You can probably just Google Missouri, it's amazing what you can find out there now. But I would start with that. And then that risk matrix that I showed you with the colors.
Yes.
I would start with that, because that, the red, the orange, that shows you where your highest incident and highest severity risks are. And so then that's where you want to start and say, okay, our biggest risk is sending someone out for a consult and either not getting results or not ensuring that we reviewed and communicated the results. And so then that's where you start with, okay, this is our process. This is where it could fail. And this is what we can do to try to keep that from failing. We can have, the nurse assigned to us every day, and most people are probably already doing this, go through and flag anything that came in that is different than, something that came in, or, making sure that we're not signing off on reports until we've communicated those to the patient, or we're documenting that we communicated those to the patient. So just making sure that we find ways to ensure that we're doing those steps that we need to be doing. But just start with where your highest risk is. And like I said, that matrix is a really good way to help identify where to start, because it would be overwhelming without an entire 10-person risk department within your organization.
Thank you.
Mm-hmm.
Okay, other questions for Tracy? So Tracy, I'll ask real quick. When I heard you speak last year, you made a recommendation for a book, and I cannot remember the name of it, but it was a collaboration of, I think, a nurse and maybe a physician that were in one of the hospitals in New Orleans after Hurricane Katrina.
Yes,
yeah.
I think it's 5 Days at Memorial. And it's one of the hospitals that was fine initially, but then when the levees breached, like their generators were in the basement. So it flooded. And so the generators flooded as well and didn't work. So they had no power. They had no air. They had to, bag all of their patients on ventilators. They had a long-term care facility within the hospital that, and it talked about just, it was a mess. There were doctors and nurses who had retreated there with their families because they thought it was going to be the most safe place, and their pets. And I mean, they talk about, the boats that never came and the helicopters that, it was all miscommunication, and a helicopter would land and they would say they didn't have any patients because they weren't up on the ramp yet. And it was a nightmare to read. As a risk manager, it just gave me horrible anxiety, but it really, really is a good book. But yeah, it's called 5 Days at Memorial. And it's a really good read if you're someone who likes big books. And, I enjoyed reading it. Like I said, it gave me anxiety, but it gave me a really good perspective on things that we don't think about. They ended up having to reverse tag patients. And they said, okay, instead of evacuating our most needy patients first, do we evacuate our patients with the best chance of survival first? When it was getting very, very dire, after they had been several days without power.
All right, thank you for that recommendation.
Yeah.
Are there any other questions?
And if you think of one, like I said, there's my email address. Feel free to shoot me an email, and I can hopefully answer it.
All right. Well, Tracy, we truly do appreciate you sharing a little bit of your evening with us tonight. And we will be, we have recorded this. So for those of you that are on the call, we will try to push this out if the recording and the sound is good through our newsletter. And you will have the opportunity then to share this with other folks within your practice. But we do truly appreciate it, Tracy. And if you have questions for her, please reach out via email. And if that's no other questions, then we're going to go ahead and disconnect the call tonight. Thank you so much to everyone, and have a great evening.
All right. Thank you all.
Thank you.
Thanks, Tracy.